Hello, my name is Leon Menezes. I'm a consultant radiologist and a nuclear medicine physician at the Institute of Nuclear Medicine at UCL and here in the Barts Heart Centre. This series of talks from the British Nuclear Cardiology Society we've recorded is to give you the basic grounding in nuclear cardiology, the applications, the technology and the evidence. We hope you find them interesting and useful. In this video I'm going to discuss the indications for myocardial perfusion scintigraphy. Discussing the guidelines in the UK and in Europe where they differ, and touching upon some of the broader indications that there are for myocardial perfusion scintigraphy. But the mainstay of the test is really the investigation of angina and the diagnosis of ischemic heart disease or coronary artery disease, and you will be faced with patients who will be telling you their symptoms, and you have to adjudicate, for instance, amongst this young woman, the older lady and the middle-aged man, as to whether they really do have, are they describing angina, do they have coronary artery disease, and what is the effect of that. The diagnostic landscape in the UK is a little bit different to that in Europe, because NICE has serially come down very much and heavily in favour of CT coronary angiography when it asked itself which of all the range of tests that there do exist in non-invasive cardiac imaging, which of these tests best predicts what the invasive coronary angiogram would look like, and unsurprisingly the answer to that question is the CT coronary angiogram. So the role of ischemia testing in the current version of NICE Clinical Guideline 95, the 2016 version, is that when patients have confirmed coronary artery disease, for example, previous myocardial infarction, previous revascularization, or known coronary artery disease from previous angiography, to offer non-invasive functional testing, ischemia testing, when there is uncertainty as to whether their current presentation is due to myocardial ischemia. And at this stage, it actually reintroduces the exercise treadmill test, which had disbanded in the earlier version. And again, another role therefore of functional imaging is to offer ischemia testing when a CT coronary angiogram shows coronary artery disease of uncertain functional significance or is non-diagnostic. And the clinical guideline treats stress echo, and in this case the treadmill test, stress cardiac MRI, and stress nuclear myocardial perfusion scintigraphy as broadly equivalent. This diagram is taken from the most recent version of the ESC guidelines, published in 2019, and they are very much of the traditional methodology. First, assess the symptoms, and clinically examine the patient, consider the patient's other comorbidities and their quality of life, and do simple testing. So, what is the resting ECG? Might you consider taking a chest radiograph? Are there some simple blood tests? Do you have a rest echo? And then it suggests that you assess the pretest probability and clinical likelihood of coronary artery disease, and depending on that pretest probability, then perform the various testing accordingly. So if there's very low pretest probability, then no clinical testing is mandated. If the increasing likelihood of obstructive coronary artery disease, then you move away from coronary artery CT to ischemia testing. And then in that regard, it says that imaging testing rather than the treadmill test is definitely preserved. And if it's a very high risk of obstructive coronary artery disease clinically, then it still allows you to proceed directly to invasive angiography, and there you might perform some sort of functional assessment with FFR, potentially. And it says the choice of the imaging test in that intermediate likelihood of obstructive coronary artery disease, your choice should be based on the clinical likelihood, the patient characteristics, their preference, the availability of all the tests, as well as local expertise. And then you would hopefully have a diagnosis, and then you can choose the appropriate therapy based on the symptoms and the prognostic value that you have intrinsically, if that test has given you that prognostic information, at least on their event risk. So just to recapitulate, the pretest probability assessment is largely based on the clinical description of the pain. Is it typical angina, atypical or non-anginal chest pain, the age and sex of the patient. And the reason that NICE guidance settled on cardiac CT is the first line, and in that case only test for that patient, is that when you do the pretest probability, only very few people are actually very high risk and very few people are actually very low risk. The vast majority are in the intermediate risk category, and whilst the Europeans allow for a certain discrimination, just assess that everyone could have a CT scan at this stage. However, MPS is applicable to all patients. You can scan everybody. There's no difficulty with imaging windows, unlike echo. There's no trouble with claustrophobia because most of the cameras are actually open, so most patients tolerate the test. Devices do not matter. Doesn't matter what kind of implants you may have, and your renal function does not matter. If you've got kidney disease and you can't have iodine or gadolinium contrast, that's not an issue in MPS. It really does suit everybody. So a more nuanced thought process to how you might approach and investigate a patient who's complaining of possibly anginal chest pain is sort of depicted here. So do you need to investigate them first of all? Are they describing you non-anginal chest pain but they have an abnormal ECG, or is this atypical or typical chest pain? Does your patient have known coronary artery disease because you know they've previously have been revascularized, or they've had an MI in the past, or they have had angiography in the past and you know what that showed? If not, then yes, go to cardiac CT. So bear in mind the absolute contraindications. Well, iodine contrast allergies are contraindication, and renal disease, although eGFR less than 30. But also bear in mind that CT doesn't necessarily work so well in certain patient populations. The obese are very difficult to image across the board if there's high levels of coronary calcium. So think about your pretest probability. Is this the 70-year-old man describing typical angina to you? Doing his cardiac CT is probably then doubtful additional diagnostic benefit. Or why don't you look at the previous CT chest or CTPA that your patient might have had, and actually look to see if there's coronary calcium. And then you can determine whether cardiac CT is actually going to be any benefit at this stage, or whether you can see that they've got coronary artery disease and you can do something else. Consider their underlying heart rate rhythm, because if a patient has got an arrhythmia, such as atrial fibrillation, sinus arrhythmia, it's very hard actually to get still pictures of their heart with CT. And again, if they've got high heart rates, which they won't tolerate beta blockade, then that's not a great candidate for doing cardiac CT. And I've put in brackets there stents. Obviously, a stent patient would be a known coronary artery disease patient, but you can't, in the same way that you can't see through lots of calcium, you can't see through lots of metal very often. But let's say you do provide a cardiac CT, very often that will give you the diagnosis, but if it's non-diagnostic or the diagnosis is uncertain, i.e. you just depicted bystander coronary artery disease because you happen to scan a middle-aged person and you still don't know whether they're describing angina, then you need to do a functional test. If they can exercise, well, at this stage, the Europeans say you might be able to perform a treadmill test. However, imaging is preferred. If you're on the known coronary artery disease limb, though, NICE says you can do an exercise test. But if they cannot, then the stress modalities of MRI, echo, and nuclear are equivalent. However, bear in mind that non-compatible devices, non-compatible foreign bodies, and are absolute contraindications to cardiac MRI. Relative contraindications would be being allergic to gadolinium. However, you could perform between stress echo or do native T1 techniques to determine the effect of hyperemia in a patient without contrast. Again, renal disease, low eGFR. Many departments are cautious with the use of gadolinium, and again, if the patient cannot tolerate going inside the tunnel. Stress echo. Well, is your patient have they had an echo before and there's been a comment on poor echo windows, then maybe it might not be best to try and repeat that with a stress echo. And bear in mind those associations, obesity again, and emphysema. If they have a hyperexpanded chest, you may not be able to get good ultrasound images. Again, there's no real contraindications to the nuclear techniques, but the fundamental principle here is to put the patient at the centre of your investigation pathway, determine their criteria and their suitability for any given test, and again, you need to work with them with what you've got. Are these tests available in a timely fashion, and is there local expertise in what's going on? Beyond unstable angina, then there is the use of MPS for, I suppose, the asymptomatic patient. What can we do there? Newly diagnosed heart failure with LV systolic dysfunction. Is this an ischemia equivalent? That is an appropriate indication for doing a myocardial perfusion scan. If you don't know that you're going to look for that their coronaries and they've not had one before, you can do an MPS. Similarly, new onset atrial fibrillation is an appropriate use of MPS when the etiology of the atrial fibrillation is unclear. Again, lethal arrhythmias, ventricular tachycardia. It's an appropriate use of MPS across the risk of the pretest probability of coronary artery disease. And equally in the course of syncope, it is an appropriate investigation. It may also help you in elevated troponin if you have no other evidence on acute coronary syndrome to determine whether there's CAD. That's an appropriate indication. We've discussed already the utilization of MPS in the context of cardiac CT, where there's an uncertain stenosis of uncertain significance, but similarly you might perform an angiogram, may not have proceeded with a pressure wire at the time, but you could bring the patient back for a functional test, and that's entirely appropriate for myocardial perfusion scintigraphy. And then the other larger category is that of preoperative risk assessment for patients undergoing non-cardiac surgery. If they're having intermediate or high-risk surgery or vascular surgery, and you don't know what their functional capacity is, performing a myocardial perfusion scan is a good surrogate. And a subject in its own right, and will be covered in this video series, is one of the assessment of viability and ischemia. And if you've got a patient with severe LV dysfunction and you may consider revascularization, then it's entirely appropriate to perform a myocardial perfusion scan. So this final slide is a list of these various indications and where they're appropriate, matched up with the advocating guidelines that says that they are kosher requests. If you're practicing in England, myocardial perfusion scanning is a second-line test after the cardiac CT. But equally, if you don't wish to perform test layering, you and your patient is appropriate for this test, then you can ask for a myocardial perfusion scan. But hopefully that sets some of the wider framework for how then these tests can be justified and scheduled. Thank you. If you found that interesting, please like and subscribe for more lectures. If you'd like to know more, follow the BNCS on Twitter and visit our website. Thank you.